So we've also looked at outcomes for patients with venetoclax. Venetoclax is an oral BCL2 inhibitor. It's currently approved in the U.S. for patients who failed, it's currently approved for patients in the U.S. with relapsed refractory disease who have a deletion 17p. That indication is largely, will probably broaden in the future, and we really don't have a lot of information about how venetoclax is being utilized at community and academic centers. We're interested in studying reasons for discontinuation, outcomes for patients, focusing on supportive care, the dose ramp up, the incidence of tumor lysis syndrome, and really just trying to get a sense, again, how when patients are treated with venetoclax, what are next therapies for patients? Is there a role for kinase inhibitor-based therapy? This is the largest data set of patients that have been collected and reported on patients treated with venetoclax largely in a relapsed refractory setting. The number is 204, and this represents a very large consortium of nearly 20 centers, both US and international, who've attempted to get together to study this particular outcome. So what we're learning from this data set is that largely patients are being hospitalized for the ramp-up period with venetoclax. Patients are receiving very maximal supportive care, IV fluids. Many patients are receiving respiricase, allopurinol to try to minimize the risk of tumor lysis syndrome, which is a concern for patients receiving venetoclax. Very few patients had complications from venetoclax, and so it seems to be a very well-tolerated agent. We saw few incidents of clinical tumor lysis syndrome, but really no attributable death to tumor lysis syndrome or the need for hemodialysis in the setting of renal dysfunction. We saw that the major toxicity following the dose ramp-up period were hematologic neutropenia, as would be expected, but that seems to be generally well managed with growth factor support and very few instances of significant febrile neutropenia or significant infection. There are very few discontinuations of this drug due to toxicity. The drug seems to be well tolerated, and the most interesting thing I think that we found is that the outcomes data, the progression-free and overall survival, very much mirror the outcomes that we've seen from the clinical trial data that have been reported so far in the relapsed refractory setting. So I think this offers us the opportunity to see how the drug is being used, opportunities for education during the dose ramp-up phase, and education for management of the few toxicities that seems to be associated with the drug. And we're starting to get insights for how patients are managed following venetoclax discontinuation. There are no prospective data available for using BTK inhibitors following venetoclax discontinuation. In this series, we have a small subset of patients who actually had been ibrutinib naive, received venetoclax, and then went on to a BTK inhibitor, largely all ibrutinib. And we actually demonstrate now for the first time in this patient population that you can see activity for ibrutinib following venetoclax discontinuation. So this gives us some insight into how one might sequence drugs, for example, in a world where venetoclax is used before ibrutinib. We also performed some analyses to try to identify patients who are at risk for poor outcomes with venetoclax, and we found that patients who have had multiple lines of therapy, patients who have seen a prior kinase inhibitor, patients who have a deletion 17p seem to be those at risk for poorer outcomes or inferior outcomes with venetoclax-based therapy. Again, an opportunity to identify patients for clinical trials for combinations including venetoclax, which may further overcome those poor risk features associated with the disease.